So we've had a very nice activity on the Q&A, and I tried to group some of the questions together so we can try to get it in with the next 10 minutes that we have. So thank you everyone for taking the time not only to be here, but to actually post your questions. I see one more. Hopefully we'll get the last question in as well. I'll do my best to cover as many as I can during this period of time. And if not, feel free to email us afterwards. So a couple of questions had to do with the subsequent testing and who should be tested. So Dr. Liu or Dr. Raphael, how many subsequent or serial tests should be carried out for a patient, and over what period of time?
I might defer to Dr. Raphael just as our star clinician.
Yeah, it's an excellent question. It's one that there's not an exact right answer to because it depends on each patient's individual circumstances. As mentioned before, another factor to consider is cost. So this is not something like the CEA or CT scans that is covered by the government, and patients need to either be able to afford it or to have a really good insurance plan to cover it. So those are some of the limiting factors. In general, in my practice, I find that the Signatera assay provides the most amount of useful information immediately in the post-operative period. So finding out that the Signatera assay is negative, and the study seemed to suggest that if it's negative at 2 time points, that provides the strongest information for prognosis about no chance of the cancer returning, essentially. So in my practice, I'm really using Signatera mostly for stage 2 colon cancer. And so we're using it in the post-operative setting and in the stage 3 setting with the appropriate counseling that we don't yet have all the information. I think it's helpful if you can get it before and after the chemotherapy. In the stage 4 setting, its use is much more limited, at least as it's currently used. There are some settings where I'd be excited to use it. For example, in patients who have colorectal cancer, liver metastases that are resected, and we want to know, do they have any residual disease and should they have any further adjuvant chemotherapy or not? And as in the example that I gave you, when the patient is considering taking a treatment holiday, if we can show that there's been a reduction in the Signatera by a significant fraction, because as Dr. Liu had mentioned in her talk, it's not just positive or negative, but there's actual quantification that can help provide additional information that if there's been a significant reduction, perhaps it'll be a very long time before you need to restart back on your chemotherapy again.
Well, that's great. So a little bit of a few more specific questions just came in as well, but I'm going to take that last one a little bit because it's quite an unusual situation. Most of the time we think of doing the test following surgery, in other words, in the adjuvant setting. What about if somebody just didn't have their tumor removed, but just underwent chemoradiation? Would the test still be used in that circumstance? Oops, I lost my sound.
So,
oh, there you go. Okay.
So yeah, so I'll talk and then ask Dr. Liu if she has any thoughts. So if I'm understanding the question correctly, it's someone who has, for example, like a rectal cancer and they're treated with chemoradiotherapy. This is actually an exciting area where circulating tumor DNA assays like Signatera can provide a lot of information. So I don't know the specifics, obviously, of the case, but for example, if we're treating someone now with rectal cancer and they achieve a complete clinical response, which is you cannot see the tumor on CT scan, MRI, or endoscopy, we're now entering a period where we're offering non-operative management and watch and wait. And so rather than putting patients through large rectal cancer surgeries that can have debilitating effects on their quality of life, we're watching them. And this is an area where circulating tumor DNA is really the most sensitive assay we have for detecting minimal residual disease, can be super helpful. Because if it's negative and you have all those clinical factors that are negative as well, I think it's extremely unlikely that the cancer is going to come back. So that's a sort of situation where I would say, yes, if I'm interpreting correctly, Signatera and like assays can be used in someone who's received chemoradiotherapy but not have surgery.
Great. So
yeah, essentially
go ahead, Dr.
I was just going to add circulating tumor DNA, certainly as we test it with Signatera, is reflective not just of the tumor where it started, but the potential for seeds of that tumor wherever they may be. Certainly there have been many circumstances where patients have not had surgery for whatever reason, and it can still be a good benchmark to understand if treatment has been effective.
Couple of questions on sample collection. So somebody had insufficient sample that was collected, so that could not be used, and they were able to go back just under 2 years previous to get their sample from a colonoscopy. Would that sample be, if it was sufficient in volume, would it be sufficiently fresh, so to speak, in order to use for the test?
Yeah, I think it's a two-pronged question. So one, we can use stored material for several years. So 2 years is certainly well within that framework. Because of the way tissue is preserved, it stays good, so to speak, for a long time. I think the other is if a biopsy versus a surgical specimen, and even if it's representative of the same tumor, but from two different sites, is that something where we can still build a reliable test? And the way our algorithms select the variants or the targets to follow in the blood is representative of the tumor sort of as its beginning and something that should persist in that tumor no matter where it goes. So it's very unique for a specific tumor itself, but biopsies of that same tumor from different places can in fact still be representative.
That's great. And here's another one concerning samples. So somebody had their blood and tissue sample done previously by either internally in the hospital or otherwise. And they would like to know two questions. One, and I guess this would be for Dr. Raphael, the first part, can they access their data from it? And secondly, can Natera or LifeLabs in this case access that data that's already stored there for a previous reason and use it for the purposes of the Signatera test?
From a clinical perspective, I could tell you in all the cases where I've done this test, the patients have gotten results first. So LifeLabs has an online portal and you get a notification when a new lab has come back. So my patients have all received the result before me because currently it goes to the clinician via fax, which is a bit slower. So the patients who do this test all have access to the results, so they see it in real time as the clinicians do.
Okay. And Dr. Liu, in terms of using previous samples from other tests, can that still be accessed by yourselves? I guess it would have to be stored at the hospital, assuming.
So, I mean, we can use tumor tissue again that's been stored. Blood for the clinical test has to be freshly drawn so that we can process it immediately to generate a reliable result. If testing was done by another company or internally, we cannot import that information to create the test for an individual.
Thank you. So here's one that's a little bit specific. They would like to know if other tests had missed metastases to their lungs, would the Signatera perhaps pick that up? In other words, lung mets in particular.
It's certainly possible. I think different tests pick up differently. So with Signatera, there have been patients who had lung metastases and the test was negative. You have to remember that there are many factors that go into the ability to detect the DNA in the bloodstream, and one is the blood supply to a tumor. The other is how fast a tumor might be growing. So one could argue you don't need or want to find every single lesion. You need to find the clinically significant lesions. And they're also, with the test, we need to do improvements to improve sensitivity of detection. There's going to be a level, though, where, again, you don't want to detect even though there is something there. And that's the fine line that we're all trying to identify now. Hopefully I answered the question.
Thank you. So here's one that's a little bit complicated, but I'm going to try to simplify it and say, is there any benefit for ctDNA for stage 1 cases?
So the answer is yes and no. So as I mentioned in my slides, there may be an era, hopefully in the not too distant future, when the staging system as we know it is refined, because stage has all sorts of limitations as I presented. So if someone had a stage 1 cancer that was positive for circulating tumor DNA, I would think that that patient, and I don't have the evidence to support this, but I would suspect that that patient has just as high a chance of the cancer coming back as someone with a more advanced stage. And in fact, I would be more worried about a stage 1 patient with positive circulating tumor DNA than it would be about a stage 2 patient with negative circulating tumor DNA when we're talking about the tumor-informed assays. Whether or not it should be done really reflects on what's the risk of the cancer coming back. If you look at all stage 1 cancers as a group, the risk of the cancer coming back is incredibly low. I've never seen a stage 1 patient in my medical oncology practice because there's no need to. They never would get chemotherapy. And so I think the answer for right now is that it's not something I would recommend outside of a clinical trial setting where more information could be collected and gathered so that we can inform patients and future patients as well.
I'm going to take one more minute to try to get a couple of more questions in because we want to make sure that we answer as many as possible. Here's, I think, a pretty quick one. Are hemorrhoids predictive of colorectal cancer?
No, none.
Okay, another quick question. From the point of view of funding, we had a few questions with respect to the funding, and we did see the cost of the funding on the previous slide, and the cost of it, or the cost of $4,500, I should say, for the LifeLabs test, and the subsequent cost of $2,000 for subsequent tests. Is there anything being done, or do you foresee anything being done either on the public funding side or on the private insurance side in order to alleviate this burden, or any other ways, patient support programs or otherwise?
So
I guess that would be for Dr. Liu or yourself.
So I tell you from the Ontario perspective, probably 25% of the times I've done the Signatera say it's been covered by insurance. So it's variable. Other times patients have had to pay out of pocket. It depends on your plan and what the criteria are for coverage. I think that as there's more information being garnered, I think that there's an increased likelihood that more insurance companies will cover it. It has Medicare coverage in the United States for many different conditions, and that usually is something that insurance companies will look at in Canada and provide coverage for. Whether it's covered at a provincial or a national level is a much more difficult question. And in order for that to be done, you're going to probably have to demonstrate overall survival benefits or, cost benefits in terms of avoiding chemotherapy and avoiding hospitalizations and that sort of thing. So I think the government covering this is at least a few years away, but insurance companies hopefully not that far.
Yeah, I wish I could ask more questions. There's a few other ones that came in. We'll try to answer them in writing post-webinar, and I do want to respect everybody's time. So first of all, thank you so much, Dr. Liu and Dr. Raphael, for such insightful comments and really for taking the time to answer these very detailed questions. I also want to thank, of course, all our viewers today. We had almost 100, and we have about 250 registrants who want to see it on our YouTube channel. So that will be available to answer that question as well post webinar. So probably just give us a day or two to get it up there, and you'll be able to review the entire webinar. I want to thank sincerely our sponsor, Natera, for giving us this opportunity, and not only to have the test in Canada, of course, but to do this webinar and inform our patients and clinicians. And we look forward to further collaborations and to answering any other questions that you as viewers or other patients or clinicians may have in the future. And we will send them along to both LifeLabs and to Natera, as the case may be. As you can see, it popped up on my screen, or say in our language, say it pooped up on our screen, a little questionnaire. So if you don't mind answering that, if you're unable to do that today, you'll get an email. We'd ask you to complete that for quality assurance on our part. And finally, I just want to thank you all for following us, and for further information, don't hesitate to go to our website at colorectalcancercanada.com or to reach us at info@colorectalcancercanada.com. Thank you, everybody, once again, and we look forward to seeing you soon.